Topic is bone replacement graft materials and procedures. Bone replacement graft materials comprise of a heterogeneous group of materials of human, animal, or synthetic origin. This type of graft comprises cortical bone or cancellous bone and marrow and is harvested from intraoral and extraoral sites. The bone graft can be categorized under four types: autogenous graft or autograft. These are the graft transferred from one position to another within the same individual. Allogenous graft or allograft. These are the graft transferred between genetically dissimilar members of the same species. Xenogenic graft or xenograft. These are the graft taken from donor of another species. And alloplastic material. These are the synthetic or inorganic materials which are used as substitutes for bone graft. Bone graft materials evaluated based on their osteogenic, osteoinductive, or osteoconductive potential. Osteogenesis is the formation of development of new bone by the cells contained in a graft. Osteoinduction is the chemical process by which the molecule contained in the graft convert the neighboring cells to osteoblast, which forms the bone. Osteoconduction is the physical effect by which the matrix of the graft forms a scaffold that favors the outside cells to penetrate the graft and form new bone. And Shallon's criteria for ideal graft material: the graft should be biologically acceptable, it should have a good predictability, good clinical feasibility, minimal operating hazards, minimal postoperative sequelae, and there should be a patient acceptance. The rationale behind the use of bone graft or non-bone graft is based on the assumption that both the regrowth of alveolar bone and the formation of new attachment would be stimulated based on these materials because these materials may either promote osteogenesis, osteoconduction, or osteoinduction. Autogenous graft materials that may retain some cell viability and are considered to promote bone healing mainly through osteogenesis or osteoconduction, and they are gradually resorbed and replaced by new viable bone. Advantage of autogenous graft is mainly the potential problems of histobiocompatibility and disease transmission are eliminated with autografts. Intraoral autogenous graft is mainly the sources are bone from healing extraction wounds, bone from the edentulous ridges, bone refined from jaw, and bone removed during osteoplasty or osteotomy. And examples of autogenous graft are osseous coagulum, mainly described by Earl Robinson. It is a mixture of bone dust and blood. Uses small particles from the cortical bone also. The sources of this bone are lingual ridge of mandible, exostosis, edentulous ridges, bone distal to terminal tooth, bone removed by osteoplasty or osteotomy, at least 5 mm from the roots. Bone blend, this is also an autogenous graft. This technique uses an autoclaved plastic capsule and pestle, and the bone is removed, tortured into plastic mass and packed into the defect. Cancellous bone marrow transplant, this is another autogenous graft. It is obtained from tuberosity, edentulous areas, and healing sockets. Bone swaging, it is requires an edentulous area adjacent to the defect. From here, the bone is pushed into the contact with the tooth surface without fracturing the bone at the base. The technique is very difficult, so the usefulness is limited. The extraoral autogenous graft is mainly from iliac autografts, and the technique was introduced by Shallon in 1967. It is fresh or preserved iliac cancellous bone marrow, but the disadvantage is that it can cause postoperative infections, exfoliation of sequestration, varying degree of rates of healing, root resorption, and rapid recurrence of the defect, increased expense, difficulty in procuring the donor material. Next category is allograft. Allograft is obtained from the different individuals of same species. So there is no additional surgical trauma is required, but the disadvantage is that it is foreign to the body, so therefore it may provide immune response. To suppress the antigenic potential, radiation, freezing, and chemical treatment is attempted. And allograft is usually commercially available in tissue banks. It's obtained from the cortical bone within 12 hours of the death of a donor. It is defatted, cut into pieces, washed in absolute alcohol, and defrozen. Types of allograft used are frozen iliac cancellous bone and marrow, and decalcified or mineralized freeze-dried bone allograft, decalcified freeze-dried bone allograft, and bone morphogenic proteins. Xenograft, that is the next category, that is obtained from different species. So the following xenografts are calf bone obtained from calf bone, keel bone, or inorganic bone. These are historical. Nowadays, we are using bovine bone. It's an osteoconductive material, an organic porous bone mineral matrix from bovine, cortical, or cancellous bone. And non-bone graft materials, the materials which were tried included sclera, dura, cartilage, cementum, dentine, ceramics, coral-derived materials, etc. The alloplastic materials which are derived frequently used in regenerative periodontal surgery are calcium phosphate biomaterials and bioactive glass. Calcium phosphate biomaterials, excellent tissue biocompatibility is there, and it does not elicit any foreign body response or inflammation, and it is also osteoconductive. Two types of calcium phosphate materials, hydroxyapatite and tricalcium phosphate. Hydroxyapatite has a calcium to phosphate ratio 1:67, and it is similar to found in bone, and it is generally bioresorbable. Tricalcium phosphate calcium phosphate ratio is 1:5, and the partially it is bioresorbable. Bioactive glass, it also consists of sodium and calcium salts, phosphates, and silicon dioxide, resorbable or non-resorbable depending on the relative proportion of these components. And next regenerative material nowadays recently added as biologic mediators. These are the molecules released by the cells or derivative of such molecules that regulate the events in wound healing, mainly secreted from macrophages, endothelial cells, fibroblasts, and platelets. And these molecules regulate the same cells that produce them, or it can regulate the other cells. So the biologic mediators, mainly the growth factors, include platelet-derived growth factor, insulin-like growth factor, basic fibroblast growth factor, bone morphogenic protein, and transforming growth factors are used. And these biologic mediators are used in periodontal wound healing. It promotes fibroblast proliferation to form periodontal ligament, osteoblast to produce bone. And another biologic mediator is enamel matrix protein secreted from its amylogenin, and it is secreted from Herdwick's epithelial root sheath during the tooth development and induced an acellular cementum formation. And it is commercially available as endogain, which is an enamel matrix protein derived from developing porcine teeth. It is available as a viscous gel, and it is delivered to the site by a syringe. And recently, we are using plated concentrate, that is blood collected from the patient, and the plated is concentrated in a centrifuge, gelled, and placed in the defect. And it contains elevated levels of natural growth factors like platelet-derived growth factor, transforming growth factor, and insulin growth factor. It improves soft tissue healing and increased density of newly formed bone. The success of the regenerative therapy using bone graft depends upon the proper case selection, understanding of the biology of regeneration process, selection of proper surgical techniques, selection of biomaterials, and integrated approach. Thank you.